Assalamu alaikum. Good evening, everyone. Thank you, Dr. Abdullah, for putting this session together. I think I'll be moving the slide. So when we're speaking about science, sometimes it's mixed with religion. And this ongoing debate between DCB and drug-eluting stents, I feel it's turning into a religion. Some are strong believers of drug-coated balloons, including myself and Dr. Abdullah. And I know that other people in the room are very skeptical about drug-coated balloons. So the attempt of this talk is to convert it from a religion, an attempt to convert it from a religion and a philosophy into the science. These are my disclosures. And you know, in cardiology, we are proud that we have evidence. Compared to any other discipline in medicine, cardiology has big trials, randomized controlled clinical trials that reflect finally into guidelines on a large number of patients. And we are proud when we follow the guidelines and say, yes, this is indicated based on the guidelines. But mind you that guidelines come at the end of the process. The process starts with personal experience, then growing into case-controlled studies, registries, small randomized trials, large randomized trials, ending in meta-analysis and systematic reviews. And at the end of this, the guideline authors, they convene together and they look into the evidence and then they stratify it into which is acceptable and which is not acceptable. So keep in mind that whatever you see, the guidelines will be lagging behind by roughly between 2, 3, and even 4 years. And it even gets more complicated because we are comparing apples to oranges when we are comparing drug-coated balloons. And it's not just apple and oranges, there are all kinds of fruits here. And it's not a battle between paclitaxel and sirolimus. We have good sirolimus balloons, we have good paclitaxel balloons. And so when you try to compile all your fruits in one basket, trying to do a meta-analysis, probably your meta-analysis will be flawed, as what happened with one of the guidelines. In addition, you need to compile evidence-based with whatever you have in hand in practice, with the tools you have, and with the patient's preference. Some patients insist on not having a stent, or they strongly prefer not having a stent. Other patients want to be more cautious and go with whatever standard or practice is there. So you need to combine the best evidence that you have with what you have in your cath lab and with the patient's preference. And it gets more complex because if you're looking for a large randomized powered controlled trial for each of these 17 or 18 situations, then I'm sorry that you will not find them. If you need a large randomized controlled trial comparing drug-eluting balloons versus drug-eluting stents in CTO or in acute myocardial infarction, we are not there yet. So what I will try to do in the coming few minutes is to take a look at the evidence that we have in different situations. And I will start where the evidence is the best. Small vessels and bifurcation. We have big studies on small vessel, which is roughly 3 millimeters or less, comparing drug-coated balloons to drug-eluting stents, well-designed studies that showed superiority or equipoise of drug-coated balloons and stents, but superiority of drug-coated balloons in patients with diabetes. When looking at bifurcation, comparing DCBs to balloon angioplasty only of the side branch, we still have a good number of studies showing the superiority of drug-coated balloons. And if you want a meta-analysis, we have a meta-analysis for the small vessel disease that showed that drug-coated balloons perform as well as good as drug-eluting stents, if not even better, in terms of myocardial infarction and peri-procedural myocardial infarction. Now we move on to the more tricky situations, large vessel disease and chronic total occlusions. And the data that we have for large vessel disease are mixed. We have one Chinese paclitaxel balloon that has failed versus drug-eluting stents. I'll show you the evidence. And we have registries mostly about other drug-coated balloons that succeeded. So when it comes to large vessel, we're still, if you want to go absolutely by the evidence, we're not 100% sure, but this has changed after the solution trial. For chronic total occlusions, we have registries. We don't have randomized controlled trials comparing DES to DCB in CTO. But if you look at the real world of CTO and the CTO operators here in the room, we're seeing a sharp increase and a very large adoption of drug-coated balloons in the CTO arena. Looking in retrospect, observational studies tell us that drug-coated balloons may be associated with less target lesion revascularization, definitely associated with less contrast and with a shorter length of metal being implanted in the coronary artery. Still, there's no large randomized control trial, but you see the horizon is expanding. These are at least 6 or 7 trials that are currently ongoing just in the field of CTO, whether in the body of the CTO or as part of an investment procedure to see if drug-coated balloons are as good as drug-eluting stents or not. So the jury is out and we still don't have an answer from evidence-based. For patients with high bleeding risk, it's very intuitive to go for drug-coated balloons. And we know from the debut trial and from a large randomized control trial that they perform as well as good as drug-eluting stents or even better. The same applies for diffuse multi-vessel disease. From different platforms, they are more or less the same. For diabetes mellitus and small vessel, we know from the basket small trial, the subgroup analysis on patients with diabetes, they did better with drug-eluting balloons than with drug-eluting stents. Now coming into more sensitive areas, acute myocardial infarction. We have only 2 studies, only on paclitaxel. That one of them was a small randomized control trial that looked into the FFR and the late lumen loss 9 months after the STEMI, and they found that paclitaxel balloon was equal to the drug-eluting stents in the late lumen loss and in the FFR. If you need clinical outcomes, the study was underpowered, but again, the clinical outcomes were the same with the paclitaxel balloon versus the drug-eluting stent. There's also a large retrospective study from the UK, from Simon Ecclesall and his colleagues, that showed that drug-eluting balloons in STEMI versus drug-eluting stents in a retrospective analysis were associated with a similar morbidity, mortality, and target lesion revascularization. But there's been a big game changer that was just released a month ago, which was the Solution study, Solution de Novo study. And the nice thing about the study, it was a strategic randomization trial. All what we mentioned with drug-coated balloons versus drug-eluting stents were comparing the performance of the balloon versus the performance of the stent. But with this study, they randomized patients before the angioplasty into one strategy of lesion modification with DCB or DAS in a minority of patients versus the standard strategy that we lived with decades, which is do a pre-dilatation or do a direct stent, but end with a stent. And they recruited a huge number of patients. This is probably the biggest randomized control trial that we have in the era of drug-coated balloons up till now. And they looked into large vessels, small vessels, even they had a few acute coronary syndrome patients. And these are the data at 1 year. Drug-eluting balloons were non-inferior to drug-eluting stents in a wide variety of anatomical situations. For the in-stent restenosis, I'll show you the guidelines, but again, the study with the Solution looked into standard of care with a balloon angioplasty or a repeat drug-eluting stent versus a drug-eluting balloon, sirolimus drug-eluting balloon, and again, at 1 year, the drug-eluting balloon was non-inferior to the standard of care, whether it was a balloon angioplasty or a drug-eluting stent. So these were the successful platforms. We had platforms that failed. Number one, the SWIDE balloon, the Chinese, tested in direct cage-free trial. And when we look at the combined endpoint of target lesion revascularization, MI, mortality, then stents did better than balloons. But when you look into myocardial infarction, there was no difference between drug-coated balloon, even the ones that failed, versus a drug-eluting stent. Another balloon that also didn't find a way was the Magic Touch balloon compared to Sequin Please. The Sequin Please performed much better than the Magic Touch balloon in terms, so the Magic Touch failed to reach the non-inferiority margin. So how does that reflect on the guidelines? The older guidelines for in-stent restenosis gave a class 1A recommendation for drug-coated balloons. But then came one meta-analysis that combined all the balloons together from different vendors, the successful ones and the failure ones, and they found that drug-eluting stents were better in terms of target lesion revascularization. So the latest ESC guidelines of 2024 recommended drug-eluting stents over drug-eluting balloons for in-stent restenosis. Is this the end? Of course not. As the new trials came, we expect that this will definitely change. But still, when you're practicing, you need to select which fruit is the most appropriate for this situation. Of course, we can discuss that at ease after the talk. But to conclude, we have plethora of evidence for the support of drug-coated balloons in different situations. The strongest indications, if you want to be very methodical and evidence-based, then keep it for small vessels, keep it for the side branches, and probably keep it for in-stent restenosis as well. If you are an early adopter and you have enough courage, then you can take it for the large vessels and for the acute coronary syndromes. And so if I imagine myself writing the next guidelines on coronary revascularization, this is my own interpretation of the data. There is no class effect for drug-coated balloons. We have excellent paclitaxel balloons and excellent sirolimus balloons, and we have failure of some paclitaxel balloons and failure of some sirolimus eluting balloons. Each platform needs to be evaluated on its own. Do not combine all the fruits in one basket. I would give a strong recommendation for drug-coated balloons in small vessels, especially in patients with diabetes, bifurcations, in-stent restenosis, especially when you have already a double layer of metal. I would keep it for the cautious physician in patients with acute coronary syndromes and in patients with chronic total occlusion. Thank you so much.